Thank you very much, Professor Vinto and Prof. Lozano. I think it's a pleasure to be given a voice for Asia Pacific. So let me just go on and just show you what I think we can move forward. Okay, I think some time ago when people talk about the heart disease in Asia, in fact, there was this quotation that Professor Sasayama mentioned that he quoted from Marco Polo and said that people desirous of knowing the diversities of races of mankind as well as diversities of regions in parts of the East. You should read this book because Marco Polo talks about the trip into the East, particularly Asia. So I think it's interesting for us to understand this because about more than half the population of the world, 4.5 billion people, are actually in Asia. And of course, these multi-ethnic, multicultural diversities are huge. And although they have common risk factor profiles, I think I'm going to share with you that there are some differences among our regional groups. But more important is because we are rapidly advancing and modernizing and aging, we also have a lot of problems. Now, if you look at the ischemic heart disease incidence rate based on just incidence rate or the death rate, there's some slight differences here. I'll just show you some first. In East and Southeast Asia, generally there's a lower incidence if you think about it. But if it is in the Middle East and Central Asia, the rates are actually far higher. Okay, and that's one of the perspectives that we all recognize. Okay, and one of the other things about this is that when you have higher risk, obviously the death rates are also higher. And this may be because of the disparities in the access to utilization of healthcare. Now, we get this from the European Society, and it tells us that, atherosclerotic cardiovascular disease has to be taken as a whole. And I think I'm sharing more of ASCVD rather than angina because the evidence or the publications for angina per se is actually not so forthcoming in the Asia-Pacific region. Now, hypertension, atherogenic and dyslipidemia obviously important. Diabetes has become a very important factor. Obesity and overweight is also gaining ground in Asia. Smoking is not really come down much unfortunately in Asia. The lack of physical activity is also important, but there may be a point about hereditary. For example, the Indian continent, Indians in particular, tend to have higher risk. The Middle Eastern Arabs tend to have higher risk. Central Asia also much higher risk. And of course, we are aging, right? So the points about diet and all that may be there. They may be present, but it's a bit hard to determine if they actually matter for us. And the stress of development probably is going to be important. Hyperglycemia is now being recognized as well without the full-blown hypertension, but we are also getting a lot of kidney disease, okay, partly because of diabetes, hyperglycemia, hypertension, which are untreated or unrecognized. Now, these are the risk factors that I think we need to think about in terms of the excess coronary heart disease mortality, particularly in the Asia-Pacific region. They're extremely diverse and disparate. In fact, I'll come to the Interheart study, which actually demonstrates to us that dyslipidemia is the most important prime factor, in particular the ApoB, ApoA1 ratio, meaning that that's tendency to be elevated LDL, but not as high as in the Caucasian countries, but the ApoA, in other words, the HDL tends to be much lower than the Caucasians. And together with their risk profiles, the risk is actually higher. Hypertension is a dominant risk factor. In fact, it may be present in about 70-80% of ASCVD in the Asia-Pacific region. Then we talk about diabetes, pre-diabetes. I'll share with you some of the data that we have. Obesity, overweight, physical activity. And in fact, these are all interlinked. The insulin resistance, metabolic syndrome, and the increase in chronic kidney disease. Physical inactivity, of course, is important. There is a possible link with the dietary differences. There's a lot of high energy, high carbohydrate, high fat diet choices. And of course, this may lead to diabetes and pre-diabetes and metabolic syndrome. Tobacco use is still a common acculturated practice, and it's going to be very hard to get rid of that. Socioeconomic disadvantages, the lower income, the newly middle income are also important ones. There are worse diet, simple carbs or more, the increasing obesity, less physical activity, worse outcomes. And of course, the ethnic distribution that I mentioned before is important. The Indians, the Indian subcontinent, the Asian Indians, the Pacific Islanders, Central Asians, Middle Eastern Arabs tend to have much higher risk. And in fact, the obesity, central adiposity, for example, is actually important. There's also a talk about higher LP little a in these communities. And of course, we are aging. Let me just show you what's happening in Asia now. We are getting to be an aged society, but of course, leading the charge is actually Japan and Korea, where there's already 30-odd% and 21%. But for even Malaysia, for example, we are not far behind. We're about 10% now. So we'll be somewhere about 15% in the year 2030. So you can see the whole of Asia is aging as well. So you're going to have an increased burden of risk for ASCVD. Now, the Interheart is actually an interesting paper. It's quite long ago now, 2004 to 2008. But it tells us that there are multi-ethnic considerations, and I think it's very important. If you look at the data that we have here, for example, you can actually see a lot of representation from South Asia, from China, Southeast Asia, Japan, even Australia and New Zealand. And if you look at it, these are the modifiable sort of risk factors that seem to pop up. Okay, smoking is important. The raised ApoB, ApoA1 ratio, in other words, dyslipidemia is important. The history of hypertension, diabetes, all those that I've mentioned before are important. But the consumption of fruits and vegetables are also low. And particularly, I think with the modernization and the rapid urbanization, physical inactivity is growing as well. And when you use all of these factors, 90% of all the attributable risk in men can be actually described to all these 9 factors, for example. Now, when you look at the ApoB, ApoA1 ratio, in other words, dyslipidemia, you know there's a sort of a dose-response curve here based on the ratio for first MI. And this is actually very rare for most of us because the LDL itself is not seen in a lot of patients that are markedly raised, but the HDL tends to be very low, or the de facto ApoA1. Now, when you look at smoking, diabetes, and hypertension, again, the ApoB, ApoA1 has about the highest risk, about 4 times the risk. But if you have a combination of all these risk factors, the more you have, the higher the risk. So again, we're talking about a mixed bag of disease presentations. So we need to look at our patients a bit more based on their features and as well as their comorbidities. Now, if you look at it, I'm just demonstrating again that the dyslipidemia is actually a very important role to play for the first point of getting heart attacks. So when you look at it, when you look at the rates for dyslipidemia, okay, it's extremely high in the Middle East, for example, in Africa, okay, 70-odd% versus, say, in Western Europe, which is only about 36%, almost double. South Asia, I mean, among the Indians and Southeast Asia, for example, you're talking about 40 to 60%, very high rates among the men and the women as well. And of course, if you take the overall men and women, you can see here, there's about 74% of the Middle East and African, as well as Asia, getting this kind of a dyslipidemia. And again, from this Interheart, if you look across the board, generally, this mismatch of the ApoB to ApoA1 ratio is about 4 times the risk. Now, what is interesting is that in another analysis in 2009 from the Interheart study, is they found there's some variations here. And for example, in South Asians, they tend to have the lowest HDL and the highest ApoB. Okay, you can see in the red line here, versus, for example, those of the Japanese, where the HDL actually is much higher, and therefore the ratio becomes much less. Okay, so there are some differences just based on that. Okay. The Chinese, on the other hand, don't have very high ApoB or LDL levels, and yet they have a sort of an intermediate risk because the HDL is also not very elevated. So I think it's important to look at that. So the first risk of first AMI, okay, just based on that, again shows you that in our region, the highest risk will be those with ApoB and ApoA1 ratio that are highest as well in the final quartile, okay, of patients like this. And it's really seen if you just separate them out. If you have a LDL that is actually higher, you also have a higher risk for odds ratio, for example. And if you have a higher HDL, on the other hand, it's a reverse tendency. In other words, you have a negative effect on the ASCVD or myocardial infarction. Now, I just want to share with you the Middle East. Okay, it's on paper looking at the Middle Eastern Arabs, and here you can see that there's a very high risk for metabolic syndrome, diabetes, and hyperlipidemia as well. And it's about 70%. Okay, with dyslipidemia is extremely high. Now, So from the Interheart and from all these studies, what we do know is that in general, the LDL levels tend to be actually 10 milligrams of deciliter lower in Asians compared to non-Asians. And more Asian cases and controls actually have LDLC of less than 100, okay, versus those in the non-Asians. So again, it's something that you need to think about. The HDL levels tend to be significantly lower among Asians, and this is a very important contributory factor. So the high prevalence is obviously one of the things that we need to address. And unfortunately, in a lot of public sector healthcare is actually not so obvious right now. HDLC may be associated, of course, with the risk of AMI across the world. So among South Asians, this is where we can get more information. The APO-A1 is actually very low, and the strongest association is with this ratio here. All right, so I think it's actually important for us to recognize this rather than just looking at the LDL, where in some of our registries, we tend not to see this link between the LDL and myocardial infarction. Now, in a recent, not too recent analysis, I think in in 2009 in the cardiology, they found that the South Asian actually has a much hidden threat. And in fact, although the South Asian population is about 1.8 billion out of 7 billion, about 25% of the population, they actually share about 60% of the proportion of the world's heart disease. Okay, much higher, the Asian Indians, okay, versus the others. Now, let's talk about hypertension. About 25% of the population, around for men and women, 20 to 25% have hypertension. Now, this is taken from the 2017 May measurement month for high blood pressure. And what is interesting is they're just looking at blood pressure above 140/90, and it assess about 1.2 million people across 18 countries. And this is what they found. Generally, a lot of patients actually were found to have hypertension. It's roughly about 1/3, I would think. This is from the Asian cohort that I'm highlighting here. But in general, 1 in 3 have hypertension, 1 in 8 to 1 in 5 are not treated. Okay, 1 in 6 to 1 in 2 are treated, but 1 in 3 and 1 in 2 are treated but not well controlled. So I think this is where there's a lot of avenue for access. Now, what about diabetes? If you look at it, the Pacific Islanders are very high. The Filipinos rank very high as well, together with the South Asians that I'm talking about. And if you look at Southeast Asians, Malaysia is getting anywhere there. Our latest count is 18.3%. It's very worrisome. This is in 2019. Okay, so the others are still about 10%, relatively low. Now, when you look at this data again, this is from the IDF. It tells you that diabetes is actually growing a lot, particularly in the Middle Eastern area in Asia, as well as in Papua New Guinea, based on those in adults, the comparative prevalence. Okay, but Malaysia too is in the region of about 18%, but you'll find that most of them are in the 10 to 12% range. When you talk about impaired fasting glucose without a full-blown diabetes, this is even higher, okay? It's more than 14% in Southeast Asia, for example, Malaysia and Indonesia. All right, and of course, the rest of the world and Africa is very high. And I think maybe because of a lack of data, the Middle Eastern numbers seem to be a little bit lower. So when you look at it, what is frightening is that the projection to 2045 is that in the Western Pacific, which includes this area here, there's going to be an increase in about 27% of diabetes. But in the Middle East and Africa, we're talking about 87% increase. And in the Southeast, which includes the South Indian community, you're talking about 68% increase in diabetes. So the burden for ASCVD and angina is going to be higher. Now, just looking at the US Biobank, the South Asian again comes out high, okay, with hypertension, diabetes, and central adiposity. And if you look at it, there are some risk factors that they think it's a bit different versus Caucasians. For example, diabetes rank very high, hypertension may be about the same, LDL may be about the same, but the HDL tends to be considerably lower. Okay, the triglycerides tend to be higher, the abdominal obesity is higher, there's a higher inflammatory marker, for example, the high hsCRP, adenopectin, as well as Lp(a). Okay, the decrease in activity, the lipid, the particle size, particularly the Lp(a) and LDL tend to be smaller, and there's also an increase in the thrombotic factors such as PI1 and fibrinogen. So again, the multiple factors, and if you look at the number in China, okay, this is even more worrisome as well. We are talking about 1.3, 1.4 billion people, and just looking at the China Health Survey, you'll find that 3/4 of them have hyperglycemia if you include impaired fasting glucose as well as pre-diabetes, whereas in the European Heart Survey, it's only about half. So we are going to face a big epidemic of ASCVD. We are not facing it right now. This is taken from a Malaysian registry, and this is actually quite alarming because 60% of our patients that present with acute coronary syndromes actually do have diabetes. Okay, and this is actually also seen more among the Indian community, which is almost twice normal. Okay, there's another paper from here which tells you about the risk factors looking at our ACS registry. And again, smoking is still considerable. You can see that 43%, diabetes here at about 55%, 70% of hypertension, and about half with dyslipidemia. So why is it important to lower LDL aggressively? I think we know that. I think the European Society has been leading the charge that we need to treat some of these preventive care better so that we can help to reduce the atheroma volume. And I think if you think about it, it makes sense. Even if you lower it so far down to less than 50, based on this study here, we know that the risk for developing recurrent MACE is actually lower. Okay, when we look at the dyslipidemia, this is one of the first papers from, not first, but a recent review from Lin. And it's very hard to see. Let me just zoom it up for you, just to tell you that these are the numbers here with dyslipidemia. This is about the population, okay? And we're talking about, for Malaysia, about 45%, looking at the average here. Singapore is a bit less, but their rates are also coming up. Philippines are very high, about 46.9%. So even when you look at this database here, it's actually pretty high. Okay, now what is worse is that the prevalence of dyslipidemia across the countries are based on different criteria. 6.2, some of them are a bit lower. And in Malaysia, you can see that we are a standout. You know, it's actually pretty uncomfortable. And that's one of the reasons why we are facing a lot of patients with disease. Thailand is actually increasing as well as Indonesia with the better data. And the Philippines is actually very marked. And also in the Gulf area, among the Middle Eastern countries, very high dyslipidemic rate. So there's a bit of a therapeutic dissonance here. Okay, in fact, the treatment for LDL, and we'll concentrate on this as one of the targets, is still far from the target goals for most guidelines. Okay, most of us do not achieve it well. And I think when you look at some of these lipid modifying regimens that we know, a lot of them, they don't change, you know. The trouble with physicians is that in spite of the difference in the or the lack of treatment, they do not change the treatment. This is shown in the green bar here. So again, this is another paper that tells you that a large number of Asian hypocholesterolemia patients do not get treated. So I'm just showing some of this example to demonstrate that, you know, we have a long way from there. So this is another review in 2018. Which actually just share with you the achieved goals for LDL. And again, getting down to less than 70 or 100 in those with a medium risk or very high risk is not and suboptimal really. Okay, across the board, you can see right up to the time of 2016. Okay, we're still not getting there. Some are a little bit better, but I think by and large, about at the most 50% get to target. One of this recent paper is found recently in the European Journal of Preventive Cardiology by Dan Shan, which had a lot of Asian input. And here, what they have found is that the LDL is still, the achievement for the goals is still suboptimal outside the Western Europe. About 32% of very high-risk patients, according to SCORE, versus 55% in the high-risk group have got optimal sort of LDL goal achievement. Okay, and of course, the non-achievement of goals is worst among women. So I think that's one of the things that we need to address. And of course, if we exclude diabetes, it's going to be worse. So the use of high-intensity statin, for example, is still not very good. Okay, there's a need to improve how we look at our patients with some of this risk profile. And I think my colleague in Singapore, Dr. KK Po, actually looked at this and found a similar response. You know, when you look at the stable angina as well as an acute coronary syndromes, about 4,500 patients. And here again, we have a recurrent problem, but the lipid control is still suboptimal and none there. So we may need to think about more aggressive therapy across the board. So I think what I want to say is that we need to look at socioeconomic factors. We need to look at the multi-ethnic differences that we have. And we need to make some sort of a contextual change in our way of looking at it. In Malaysia and in Asia Pacific, there's a lot of interventional thought, treat rather than in terms of after the fact that the patient develop a myocardial infarction or unstable angina, rather than do a lot of these counseling and other clinical preventive measures. And in fact, I think ESC rightly points out that if you actually reduce cholesterol in particular, or hypertension, or reduce the rate of diabetes, you're able to do much better. And in fact, when you look at this very old slide, it just shows you that if you actually look at population health strategies, you are able to do some much better. And single strategy is all to be there, but if you are going to be more successful, you just look at the risk profile alone, you may not be able to do much. So having said that, I think what we need to do is that we need to reduce the blood pressure better for the community, the reduction in the cholesterol, and together, I think with the optimal control, you'll be able to get a much better outcome. So my conclusions are that ASCVD and the China burden is still growing in the Asia-Pacific region. Hyperlipidemia is manifested by the ApoB, and the A1 ratio is often associated with multiple comorbidities. We've mentioned that the rising prevalence of obesity, diabetes, hypertension, sedentary lifestyle, unhealthy dietary habits, tobacco use, and the actual levels of LDL may be lower than similar cohorts in developed countries, but nevertheless, the risks are higher, if not more. There's always a lot of metabolic syndrome and healthy sort of a lifestyle and diet. In many Asian countries, and particularly India and the Middle East and the Central Asia, the rates are higher, if not similar to the Asian American cohorts. So there's a therapeutic dissonance. I think we are not treating our sort of risk factors properly. But I think maybe Japan, Taiwan, Korea, and China have improved, but I think for the rest of us, we're still a long way from there. And we need greater physician education and recognition of this conundrum in order to stem the rising ASCVD, especially the younger first-time myocardial infarction incidents in the region. I think we need to have a closer adherence to guideline management for CV risk factors. We need to use the guideline sort of a directed medical therapy to bring down these risk profiles to target. Unfortunately, in Asian countries, there's a greater emphasis on very costly interventional therapies such as PCI. And this is deemed more advanced and maybe more modern and more fashionable. So I think there should be a better focus on primary and secondary preventive measures for better health sort of resource utilization. So with that, I thank you very much for your attention. Thank you.
Thank you so much. It's really a great, fantastic presentation, and it gave us a lot of data and a lot of information on the picture in Asia and a little bit on Malaysia. We do have a few minutes for some questions and for some discussion. You can also use the chat if you want to ask any specific questions. But actually, I will start by asking you, it's clear, and you showed that very nicely, the different rates of disease, of ischemic heart disease, and even of the different risk factors among the different countries in Asia. How do we explain that? Is that just simple cultural, diet, genetics? What are your thoughts on all this? Because some of the differences are quite substantial. So what is your view on that?
Well, I think there must be some genetic predisposition as well, but I think more of it will be related to cultural as well as dietary habits as well. If you look at the Middle East, for example, there's a great increase in diabetes, for example. And I think inactivity may be one of the main factors there. But if you look at the South Indians, the fact that they have a lower ApoA1 or HDL or gene tends to be a major factor. I think we have seen among the Asian Indians, as I pointed out in the slide, multiple risk factors that they have. And one of them may be the tendency to have a slightly higher Lp(a), which is again more likely to be genetically determined. They also have much higher rates for diabetes and this, and hyperglycemia. But to pinpoint exactly, there are some gene variables that have been actually discovered. But I think so far there's been no appropriate sort of polygenic sort of a risk assessment that actually can quantify the differences.
Yeah, that's I certainly agree. Do you check Lp(a) on a regular basis in your?
Not little a, but I think for me, I think among some of my patients, I can actually encourage them to do it. The price has actually come down considerably for the testing. So when I do a bit of a apolipoprotein sort of a check, it's actually not too bad. I mean, we are talking about 30 euros if they can afford it, that sort of thing. And then in research protocols, it can come down to about 5 euros. So it's actually worth thinking about it.
Yeah, maybe that answers. There's a question from the audience, but why is the lower penetration of LP(a) and ApoB and ApoA in routine practice? Would that be a just cost related, or what's your opinion?
It's a bit hard to actually. I think part of it is because of the cost in doing the test. I think if you remember from the Framingham, we didn't even do LDL or the thing, it's just total cholesterol. But then later on, as we do more and more, it becomes a bit more available. So I suspect that if you do this, of course, during the Interheart study where Malaysia also participated, we have some funds that we actually looked into the ApoB and the ApoA1. And because of that, we were able to get some data, right? And remember, this is in 2004 when we started the study. So it's not impossible to do. If we just have that mandate to do it, I think we can do it.
And have you seen any significant change in these risk factors prevalence over the last, let's say, 20 years or so? Do you see any improvement?
Unfortunately, we don't see much of an improvement there. Just take Malaysia. Our hypertension control is better. We have actually flattened the curve. It was projected to go up to about 40%. In fact, we have come down from about a high of 35 to now about 30% of the population. So that part of it, I think from a population sort of a base management, like reducing salt, and which is always constantly drummed up to the public, does help. Unfortunately, diabetes has gone through the roof because people are just a bit more sedentary and there's just too much of carbohydrate consumption in the country. We're talking about 18.3%, one of the highest. It's close to the Pacific Islanders. And so it's a very bad thing. We are trying to put in a lot of efforts to reduce diabetes. I think it's due to diet as well as physical activity.
Yeah. Well, one of the things that you showed, and that's unfortunately a common problem we have all over the world, is the percentage of patients that we are actually treating with either diabetes or with dyslipidemia. You showed dyslipidemia, 60% of the patients with ACS, they have diabetes, and many of these, they are not properly managed. So how can we improve the management of our patients? Dyslipidemia, for instance, we have good drugs in there. We have statins, we have ezetimibe, we have now PCSK9 inhibitors. How can we what sort of strategy can we develop to improve the number of patients that we can actually treat, knowing that we can have much better results if we can treat them?
Yep. I think the important thing is to develop national guidelines. We have been updating our national guidelines on how to treat dyslipidemia, for example, and the more regular use of statins and ezetimibe. But unfortunately, because of costs, I think for the original products, it tends to be low. The use of PCSK9 is still relatively low, but I'm quite happy to tell you that we have got some good generics now for ezetimibe as well as for the statins. And I think that will help in a long way to getting there. But more important is to get the public hospitals to recognize that you need to lower the LDL. So I think the story has to be that you have to control our risk profiles much better than we have, and not just let the patients develop whatever they have, based on their choices. We need a constant barrage of information to share with them.
Do you think the use of there's been some discussion on the use of polypill and fixed dose combinations. Do you think that can help in terms of providing better patient adherence and maybe lowering the costs?
I think it will probably help, because every little bit helps, because you want to talk about the overall burden. I am particularly impressed with just lowering, if you can give a good dose enough for a, say, moderately potent statin together with some, ACE inhibitor, calcium channel blocker, or beta blocker. And especially, I think in India, there was actually a polypill that was being tried. And you can actually reduce, even if you reduce 5 millimeters of mercury or blood pressure, it's going to do a lot in the long term. And same thing with the LDL. So it's that total burden over time, which I think can be useful. I'm a bit I'm skeptical about the folic acid right now because we know the homocysteine reflects inflammation, but reducing it doesn't seem to do much. So I am not so sure whether we should just go on with that.
Well, I think it's been really delightful to have this chat with you, David. It's been some time we have not seen each other face to face. I really hope we can do that
Barcelona.
soon. I hope we meet in Barcelona. It was
Great
a
meeting.
pleasure to have you here. Thank you so much.